Welcome everyone to our ED Stop Suicide QI Collaborative Session 2. Next. My name is Laura Aird, and I work at the EMS for Children Innovation and Improvement Center on Collaboratives. We are so glad that you're here today, and I wanted to mention that if you wanted to say hello, you're welcome to put your name in the chat. Next. We are very grateful to our HRSA colleagues for sponsoring not only the EMS for Children Innovation and Improvement Center, this collaborative, but also today's event. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. Next. A few reminders. Nursing professionals, as well as others. We are able to offer MOC Part 4 credits for physicians, contact hours for nursing professionals, and CEUs for social work professionals. There is information near the end of the session about how exactly to access the evaluation session or section specific to you. Nursing professionals, we do need you to enter your name into the chat box to account for folks who may be in group rooms that wouldn't show up on our registration log. Please note that all of you will remain on mute throughout this session, and it is being recorded. You'll notice that we have a Q&A box as well as a chat box. So please put your questions in the Q&A box, and the speaker panelists will attempt to answer your questions throughout the session. We know this is a long session, it's 90 minutes long, but there's a lot of very important and interesting and exciting information. Just a reminder that we need to register for each session and fireside chat individually through registration links that you can find on the web page, which is throughout this whole entire presentation. And please wait and complete the evaluation survey, which is near the end of the session. Thank you. Next. These are the session objectives. Next. Here are the topics we are going to cover today. We're going to remind you who your colleagues are in this collaborative. We're going to help you plan your quality improvement project or improvement process. We will introduce the intervention bundle guides to you by topic areas as listed, and we will help you prepare for future collaborative sessions where you will be sharing information with us about your team, your ED site, and the project or improvement process that you wish to embark on. And if there's discussion time, we will allow that as well. Next. Here are the experienced speakers that you are going to hear from today. Next. So, because this session is a bit longer, we do have some poll questions for you. You can see them on your screen. What is your favorite movie genre? Yes, we're sorry, we did not put in comedy. I think most of you have answered the questions, and it looks like most of you prefer the same as I did, action adventure movies. So that's awesome. Other folks are indicating that comedy is the best. Louis, I believe we can move on. And Christina, you can change the slide. Janet, I believe I'm turning this over to you now to talk about our demographics.
Sounds good. All right, so what you're seeing on the screen are the states that have teams. Later when we talk about PMHCA, there's another map showing the overlap. And if there's any questions, you can ask. So you all represent a total of 86 teams across 31 states, accounting for 338 individual participants. And among the 86 teams, over 60% include pediatric emergency care coordinators, or PECs. Establishing a PEC is one of the key drivers of overall pediatric readiness. And for those of you serving in this role, we hope the content and QI framework described in this collaborative can be used as a foundation for much of the future work that you do. And for those of you who did not receive or did not report a PEC, the work upon which you are about to embark more or less places you in the PEC role, or of driving pediatric emergency care improvements at your site. The majority of PECs spend their time enhancing clinical care processes, implementing QI programs, and educating staff. And this is exactly the kind of work we will be doing over the next 9 months. You can go to the next slide. So here we have some more demographic breakdown. So we'll start on the left with the ED configurations. So first we'll look at general ED, and these are pediatric/adult patients seen in the same area. In the orange, we have pediatric ED and children's hospital. So these are hospitals that care only for children. And we have separate pediatric ED in a general hospital. This is adult and children within one hospital. And then we have standby ED, where we have a physician on call. And if you look to the right, we have descriptors of service areas broken down by urban, suburban, and rural. And at the bottom right, we see annual pediatric volumes, where low volume is indicated as having less than 1,800 kids per year, medium being between 1,800 and 4,999 kids, medium high at 5,000 to 999,000, and high over 10,000. All right. And here we have some additional demographics. So years worked in the ED, we wanted to see years of experience. So we had a breakdown of 10 plus years at 45.3%, followed by 6 to 10 years, 17.4%, 1 to 5 years, 27.1%, and less than a year at 10.1%. And on the right, you'll see a breakdown of the credentials that you all hold. Just want to acknowledge that there's a great diversity in the credentials here across the board. So really exciting to see all of you participating in this work. All right. So there was a question about if you have had formal QI training. So if you're feeling a bit unsure about QI methodology, don't worry, you are definitely in good company. We will walk you through your improvement effort. So while many of you have not participated in a collaborative before, we really appreciate you taking the risk and initiative to join us here. Past participants have reported how beneficial it is, or it was, to implement this work as a part of a collaborative. Not only is it a lot more fun when you're working with others, but it is a much more efficient way to achieve your aim. So you're in the right place. All right, I'll hand over to Kate.
All right, great. So we're so excited you all are here, and we love the diversity of everyone who's here. Hopefully you recognize that. And I know over the course of the next 9 months, you're really going to value the wide representation within this collaborative. And we thank you for being on this journey with us. I wanted to just share high level what we're doing. And we've talked about this a little bit during some of the previous sessions, but we use the Institute for Healthcare Improvement's Breakthrough Series model as the foundation for our quality improvement collaboratives. And this is maybe a little bit of a complex diagram, but it at least gives you a high level sense of where we're headed. We've spent the last 6 to 12 months working really hard to build out content, support tools, resources, and the like to be able to help you make these improvement efforts. We are now at really learning session number 1, or LS1 on that diagram, and are getting ready to embark on a series of plan, do, study, act, or improvement cycles. And we'll talk to you all a little bit more about that. In a few minutes, Jen's going to come back on and she's going to talk in more depth about the model for improvement and what that plan, do, study, act cycle really means in terms of your implementation efforts and implementation work. Next slide, please. While we're all working towards this shared goal of improving our clinical care processes for children who present with suicidal ideation, we know that every single site is at a different stage or phase within this work and has a different set of resources available. If you are early in this journey, we recognize that really focusing on things like suicide screening or those in the earlier aspects of the care process may be the easiest to accomplish. For those of you that are in more advanced forms, you might find that some of the later phases of the care process are a better fit for you. But really, any or all of these areas of focus are perfectly great to choose for your improvement journey. And we'll walk you through some of the steps to do that. The last piece, and next slide, please. The last piece I just want to emphasize is the importance of your team. We've asked you a lot of information over the last few weeks about you, about your team, who's on your team, who's part of your site. And it's really important to just be thinking about the multidisciplinary nature of this team. We know that when it comes to, assessments, we might want to have mental health professionals, counselors, licensed psychiatrists or psychologists that are working with us. If we're looking at ED-based interventions, security may be a more critical element, but really be thinking about the skill sets that you need to impact these changes. And the last thing that I just want to reiterate about this is that one of the base or foundational tenets of quality improvement is making sure that you're engaging those that will be most impacted by the changes. So if you're trying to implement new care processes, you want to make sure that you have the staff who will be impacted by those care processes engaged in this work too. And then on the right-hand side of the screen is just a tool that we commonly use in quality improvement science. It's called a stakeholder grid. And the idea of this is it can help you to identify individuals who you may not have initially included on your team. And it's certainly not too late to grow your team. So really thinking about those individuals within your institution that have a high level of interest in this work for a variety of reasons, and those that have a high level of authority or power or influence within the organization to make these changes happen. And if you were to map out individuals within your site and on your team, it's highly valuable to really consider where they would fit within this stakeholder grid. So with that, I'm going to turn it back over to Jen, and she's going to walk you through the QI project.
All right, thanks, Kate. So as Kate mentioned, the IHI, wow, model for improvement is an effective approach to addressing specific quality issues. So again, as the name implies, this approach is a really good example or model to follow, as it's one of the most commonly used QI approaches in healthcare today. So the model consists of 3 essential questions. The sequence of addressing these questions is not necessarily absolute, but addressing all 3 questions is crucially important. These questions require us to define our aim or our specific desired point, and how you will know the changes in improvement, which requires measurement and the changes that can be implemented to lead to improvement. So really using this model, let's walk through the process and a few tools as we travel down this QI road. So you can go to the next slide. So there are 3 key questions signified in the diagram to the right. So the first is asking, what are we trying to accomplish? And that's really your aim. Looking at what change are you seeking and by how much and by when. The second question is looking at how will we know the changes in improvement. This is specifically looking at measures. You want to know, is this change truly an improvement? Are your efforts actually contributing to the improvement you're seeing? And then specific measure types, which we'll go into in more detail, are structural, process, and outcomes. And then finally, the changes, what change can we make that will result in improvement? So looking at what changes or the change strategies that you're going to implement will achieve your aim, and can these be measured? So we'll go to the next slide. So let's look at the first one. What are you trying to accomplish? And the first question really focuses on what what we want to see meaning is what is the performance or outcome or basic structure that we wish to see. Some might phrase this as defining the problem you were trying to solve. So in defining this, we create SMART aim statements. Some often create a global aim or purpose first before creating the aim statement. It's simpler to create and can help your QI team better understand the issue. We have discussed the aim statements in prior sessions. So let's walk through an example QI effort to see these steps in practice. So in this case, we are using a purely fictitious and simplified example. And so over the next few slides, the example statements will be included in the green focus boxes. So in this example, we use things like our environmental scan, surveys, and maybe even a process map to help define our aim statement. And an example of our aim statement is by August 1st, 2023, we will increase the appropriate utilization of analgesics to pediatric extremity trauma patients by 20%. So as you notice, the intention to include a very specific, measurable, achievable, realistic, and time-bound statement is very important. And again, this is just a simplified example for illustration purposes. And so there we go. So your aim statement will define the change improvement that you want to make. The more specific you can be, the better. Again, when we mean by the SMART goals, it's specific. So again, you want to be direct, detailed, and meaningful. Measurable, you want to see if these are quantifiable, measures in progress. You want to make sure that your aim is achievable, that it's realistic, and you have the tools to accomplish it. You want to make sure that it's relevant, it aligns with the organization's mission, and also time-bound, it does have a deadline. And again, on your left, you'll see examples of what SMART aim statements look like with those criteria met. And then here you'll see an aim statement template. So again, to help you construct your aim statement by a specific date, hour, institution, agency, group, whichever the group it is, will improve what? They'll improve an issue, a topic of your choosing. 4, defining your population or patients. By looking at the degree or amount that you're looking to make this change, and as measured by, if you have this information, including your measurement method. All right, so as we're moving down the box, looking at how will you know that a change occurred and it's an improvement. So using our model, our next 2 questions can really be addressed in either order. So we'll start with the second question. Again, how do you know that a change occurred and is it an improvement? So this is the time to carefully break down your aim statement to determine what change you're looking for. And then we determine ways to measure now not only that the change has occurred, but to what degree was this change meaningful and how much did that change occur? So if you take a look at, you might want to consider taking a look at data systems within your organization. Also considering looking at for standards as a starting place where change may already be measured. And as a result, data systems are already collecting this data for this change. So again, not necessarily reinventing the wheel. If you know that there are other sources out there already collecting this information in some capacity, that is a great place to start. And in our example, we've chosen to query our EMR system to gather specific data. So since we already measure pain and medication as well as adverse event occurrences, we don't need to create any proxy measures. This information already exists. All right, so looking at quality measures, we haven't really spoken much on this topic of measures because it can be a little bit more complex. Just to let you know, analytics professionals are a great team member to bring into your team for this very specific reason. And as we work to define our measures, we can ask ourselves these relatively simple questions to guide us. So looking at what is ideal, how would you measure it, how can you measure it, and what data is already available. And so in the end, we must define those measures that will inform us of the change that occurs after implementing our change strategy and the degree plus direction of these changes. Measures can be related to outcomes, to process, or to indirect results generated from our changes, which are called proxy or balancing measures. All right, we'll go to the next. Yep. So let's break down the 3 different measures. You may have heard us speaking about structural process or outcomes, and so we'll break that down a little bit more. So this is a commonly utilized model for evaluating health services. This is accredited to Avitas Donabedian, a physician and researcher out of Michigan. So this model uses 3 types of measures as a guide for evaluation. Those who have studied systems evaluations may already know this approach as involving inputs, activities, and outputs. So this slide provides examples of what you might measure in each of these categories. And it's not necessary to have measures for each category in every QI effort. Would be nice, but not necessarily necessary. So most often we all wish to focus on outcomes. The reality is that we do need structural elements in place in order for processes or activities to be able to be carried out. Without processes or activities, we have no outcomes. So all of these are important. If you have effective structural elements already in place, then there's no need to measure these. Most of your measures will likely be processes and outcomes, unless of course your QI effort is in an area that lacks structural components. And we mentioned this before, a fourth category of measures often utilized are referred to as balancing measures. Some refer to these as side effects or side effect measures. These measures seek to determine whether our change strategies created an unintended or undesirable effects. So ideally, we'd like to have the greatest improvement on outcomes with the most minimal, infrequent, or low impact side effects. So with all of that, let's review where we've been. So beginning with your improvement project and really starting here where you're effectively addressing the 3 questions that we've posed at the beginning. From there, defining what you wish to accomplish. What are you seeking to improve? From there, you can draft your global aim statement or your aim statement being specific, measurable, achievable, realistic, and time-bound. Establishing your team is important. Again, if you don't have your team fully established, work to identify those best team members for the project, considering a multidisciplinary approach. If you have your team, you can gather your team and provide background info, and then really work to refine your SMART aim and your hypotheses. From there, you want to define those relevant measures and data sources from the get-go. And then working from there, identifying those key drivers and potential change strategies that you'd like to implement. So our next steps are to identify one specific change strategy that you plan to implement in your improvement effort. This change strategy is the one that we will then plan to implement, or our do phase, and then study the results to determine how we will act after the cycle is completed. All right, you can go next. So from here, let's review the process for what I'll go into more detail around the PDSA, looking to predict and plan. This is the first starting point. So in identifying that change strategy, you really want to work to plan the what, the who, the when, where, how, and what data you're going to be using. The do is where you're implementing the change strategy and documenting those observations, as well as collecting data. From there, you'll study the results of that data and reflect on the plan, compare to any predictions that you made prior. And then from there, you'll either adapt, adopt, or abandon that plan. And from there, you might determine that you might need to plan a more impactful change strategy. So depending on where you are, you might adopt the plan and celebrate and share your success. Any of it should be celebrated no matter what, even if you have to go through the process again. So you might decide that, hey, this was great, but you need to continue improving. That's okay. From there, you'll identify your second change strategy and go through the process again. All right, we'll go to the next. Yep. So here at that last question, what changes can we make that will result in an improvement? So these change strategies include, determining what change efforts you want to test, what will help to ultimately lead to an improvement. And then change strategy should be small and short in duration, really no more than 2 weeks. And again, this question can be addressed either last or around the same time as how will you know that a change effort is an improvement. So these kind of go hand in hand. But some sources that you might want to consider when looking at change strategies, looking at findings from evaluations and knowledge assessments that you might have conducted. Also looking at defined measures to demonstrate improvement. Do you have measures defined at the outset before you work on these change strategies to see if you can actually measure, did you make an improvement? And then finally, considering evidence-based literature and our best practices gleaned from other institutions. So again, if a lot of work's already been done in this area, no need to reinvent the wheel. You can build on already existing best practices. All right, so we'll dive into the key driver diagram. And there are 2 images, one of which can't fully be seen, but the first is really defining the why. So that's your SMART aim. You're like, why are we here? Why are we doing this? The what, those are your key drivers. So what will increase the likelihood of achieving your aim? Those are the components that are really going to help drive your change efforts. And then the how is finally those interventions that you're going to implement to achieve your aim. So how will you accomplish this? And those are your interventions. So this is an example of a key driver diagram. Again, on the left is your SMART aim. This is your why. The key drivers, again, are those foundational components that are really, again, driving that work. So awareness of guidelines, cultural change, parental buy-in, these are kind of structural in nature. And then the interventions, those are the things that you're going to be implementing to achieve your aim. So really want to highlight that the PDSA cycle, it really is iterative, and it's not intended to imply that improvement comes from one singular simple change. That would be awesome, but highly unlikely. Improvement often requires a number of attempted changes to then give us our intended or desired improvement. So as you can see in this graphic, we've used the example key change strategies from the last slide. So each cycle uses one specific change to test and measure at a time. The first cycle is in this example could be educating staff. During this, our measures might find that this helped a bit, but we didn't reach the level of implementation or improvement that we desired. So then we decide our next change strategy was to implement a policy and all the changes that go with a new policy implementation. So from there, we measure that change to see whether we had an improvement, and equally important was that change in improvement, the improvement that we are seeking. And you repeat the process for each unique singular change and cycle. This is where it becomes cyclical and kind of builds on each other. So looking at the PDSA cycle kind of as a whole, again, looking at the top, defining those key questions and developing theories and ideas. From there, you're planning, you're predicting what's going to happen. You're defining the what and who, the when, where, and how, and then determining what data you want to collect. From there, you'll implement that change and document what occurred. And document any problems along the way too. If it didn't necessarily go right, didn't mean it was a failure. They're learning experiences, and it's just an opportunity to collect more data. And then the study, again, analyzing the data and results, and really reflect on your plan to see, does it compare to your predictions? Did you see a change actually occur, and was it related to your interventions? And more importantly, just what did you learn from it? And then from there, you'll determine your actions. Again, defining your next steps, determining whether you're going to adopt the change, you're going to adapt it, or ultimately abandon it. You can use tools such as the key driver diagram or a fishbone diagram, and really work towards planning a more impactful change strategy. And again, this process can repeat numerous times. All right. So we do have intervention bundle guides. These guides are meant to provide ideas, resources, and reference materials for each of your teams. These are meant to be brief and really to support your project work. And the overall structure of these guides will provide background on talking points, aim statements, defining quality measures, intervention strategies that you can implement, and additional resources. And all of these can be found at the following website. So next up, we have another poll. Let's see if I can do this. Oh, there we go. So after learning about SMART aims, which characteristic do you think is most often missed or forgotten? I see time-bound and measurable are jockeying for position. All right. Seeing a lot of you are answering. Give it another moment. All right. It appears majority right now are answering that the measurable component is often a characteristic missed or forgotten. I would agree with that. I think we're really good at defining like what we'd like to work on and what we'd like to see changed, but the measurement component is often left out. We need to determine that from the outright. How are we actually going to track, was this an improvement? All right. Now I'll hand this over to Angela.
Thank you, Jen. I am, now that we've talked about QI, I know those of you who are clinicians, QI sometimes is a foreign language type, but this is what we'll get into next is the intervention bundles, and then you can kind of start coming up in your brain, kind of how are you going to apply this? In which bundle are you going to choose? So the first one is the suicide screening, and that's oftentimes one that's kind of tricky of identifying what does that process look like. So suicide risk identification and screening is a top priority for the World Health Organization, the American Academy of Pediatrics, Joint Commission, and the National Institute of Mental Health. So, and for those of you who haven't noticed or seen in some of our presentations before, suicide is the second leading cause of death among children 10 to 14, and is becoming a top 10 cause of death for children as young as 5 to 9. So why screen? Why do universal screening? Why create this project? It's to identify those who are at greater risk for dying by suicide. So we've identified that this is a problem in our children, and as a society, we're not screening them and we're not providing the interventions that are needed. And we know that a lot of kids come to the emergency department, so we need to do our part. And we need to provide life-saving resources. So screen, what do we do? Including care for the child while they're in the emergency department and creating that safe environment that promotes growth and health. Next. So the global aim of this bundle is 100% of sites participating in or selecting this bundle will have a process or guideline that relates to universal screening of children over 10 years of age using a validated screening tool. So as Jen talked about, there's different ways that you can measure this. One is the presence of a clinical care pathway or process that recommends universal screening for all children over 10 years of age. Another way that you can measure this would be percentage of physicians and nurses who demonstrate high-level knowledge in using that validated screening tool. And then measure 3 is what we identified as stretch goal, mainly because not everyone has access to pulling the data and really looking at the documentation. So all 3 of these would be a good solution to getting you on the pathway of making sure you're providing that safe care. Next. So going back to the measurable part, how would we measure this? So for the second measure, the first pathway, for this measure, you would want to figure out how are we going to measure the knowledge of staff. So we would need to create a data collection tool. We want to, some of the questions could be, do staff know what tools being used? Do they know where to find resources? Do they understand how to use the tools? When and where to use the tools? And then some kind of self-assessment of knowledge or comfort proficiency after the training. So generally a 5-point Likert scale has been well adopted and used in these so that you can kind of gauge where people are at and growth. And so that's all fine and well, measuring baseline or maybe right after your training intervention. But research has shown that up to about 6 months, people can lose that knowledge if they're not applying it regularly and getting it reinforced. So oftentimes, and sometimes it's easy once you learn it, but then actually when you go to apply it, you realize maybe I really didn't understand the process, which causes more anxiety or hesitation. So oftentimes, good training is at the elbow or skills or Sims lab, and where they get to practice the process, having a skill set checklist so that you're kind of looking for in real time with someone, what knowledge they need to know. So it depends on what resources you have access to, but just kind of knowing the different levels of quality of the data that you can pull and knowing what your end goal is that ultimately is to provide the quality care, not just to measure, check a box that we got it done. Okay, next. Okay. So the third one that we said was a stretch goal is really identifying how are we going to find the data. So collecting the data. And so the evaluation of compliance with the suicide screening can be tracked in real time or retrospectively. In real time, there's positive that you can correct course in real time. You can problem solve with the people doing it. But that's oftentimes not realistic if you have a high volume or if you have a smaller staff that doesn't have the ability to collect that. So the other option would be retrospectively. If you do that, you have to identify specifically how you're going to select the charts. Again, if you're a system that has IT support and a very have access to an analyst, have a good EMR system that can easily pull that, you can come up with the data points of ages, if the suicide screening was done, looking at key risk factors and looking and having that pulled for you. If you're doing it manually, you also have to identify, so how am I going to do that? So manually would be identifying, every 5th patient. That's an example of having the systematic approach of pulling, and it doesn't create bias. So every 5th pediatric patient over 10 years old would be pulled to identify if they met the criteria that you were looking for. Random selection, stratified sample, things like that sometimes can lead to bias. So you really want to make sure that you're doing it in a way that you're not just pulling charts that you know, that you're really looking across the board. So you're not identifying, just looking at certain types of charts or ones that certain people raise up to you. Most importantly, getting the data, good data is wonderful. But then the whole purpose is to identify why, if it's not where you want it to be, and generally, like in our fireside chat, we talked about 90% of compliance is generally very achievable once you implement universal screening. You want to determine why. Why is it not working? You want to go to the people who are not able to do it. It's particular times of days. Is it the process isn't clear? You really want to identify why it's not being improved, and then kind of working towards that. So ultimately, that's the goal. It's not to just get to a certain point. It's to really improve and having that built into the culture of your emergency department. Okay, next. So this is an example of a key driver diagram for this bundle. So using the just an example of what an aim would be, establish the universal screening of children over 10 years of age using a validated screening tool. And again, the idea behind the key driver is to help create bucket areas for potential change strategies. So it may seem like a huge issue. So it's really breaking it down into chunks, into steps, and then kind of coming up with strategies to meet those. So above, as you can see, or it's, communication, education, those are really your key drivers. And this is the what you're going to do on the other slide. So with an example might be communicate to staff about the importance of suicide screening. That might be your first step. You really want to make sure that you have a very mindful approach of how you do this and not try to roll all of this out at the same time. So really being thoughtful around, maybe we'll communicate first, we'll assess the culture, we'll do education, but not trying to do everything at the same time, because then you're not really sure, your PDSA cycle might get really confused and you don't really know what parts need tweaked or what parts need to be really looked at. And so you don't abandon the whole project. So kind of going through this again, looking at it, there's different areas to really get down into. I know that in the one that Jen had shown, had arrows pointing to multiple buckets. So knowing that this is not just one bucket, it could be multiple buckets that you're pointing the arrows to for the key drivers. So just being aware of what are the different things that you want to look at and address. Okay, so next. So in addition to the content within the intervention bundles, we've shared resources for you, like validated screening tools. That's very important. The fireside chat that was led by myself and Dr. Jackie Fallon is also on the ED Stop webpage. I think Laura has put that in the chat. If you need it to have a refresher, the slides will also be online if you need refreshers as well. I know we're going through it quickly, and there was some QR codes on there as well for additional resources. Okay, so I'm going to turn it over to Kate for bundle number 2.
Great, thanks so much, Angela. So we have 3 more bundles to go through. So we're going to walk through these. And just as a reminder, as Jen presented, we're going to go through kind of what's in these bundles. So starting really with talking points or background. And the reason that we're sharing this with you is that these are great talking points that you can use with your team as you're trying to decide on a project, that you can use with ED or hospital leadership as you're trying to get buy-in for this work, and also as you begin to communicate with other staff about the importance of the work that you're doing. So just encourage you to think of it as how you can use that for implementation. The rest of the steps, I know we're talking about some quality measures, just to give some background. So the quality measures that we're presenting in these bundles were ones that went through a vetted process through our advisory council members. So subject matter experts really weighed in on what they thought would be most impactful. They are merely suggestions, however. You are not required to choose any particular measures. You are not required to accomplish all of the measures in a given bundle. It's really up to you and your site on how and what you accomplish over the course of these 9 months. So I just want to emphasize that. Then within each of these bundles, there's lots of resources and information and ideas about potential change strategies. So that's what we're going to continue to walk through. So for intervention bundle number 2, this is the mental health assessment. And it's important to know that mental health care provided by physicians only may actually be insufficient to meet the needs of children in a mental health crisis. And so for that reason, it's recommended that every child that's at high risk for suicide receives some kind of evaluation by a licensed mental health professional. Now, there is a survey of PEDS clinicians that emphasize the importance of specialist training in mental health personnel, but this can be implemented in any ED, really, regardless of specific resources. A team-based approach is really been purported to be one of the best ways of implementing this. It's just important that if you do this, that it be embedded into the entire systems of care framework. And these types of team-based approach to the mental health assessment can help to improve organization and flow. They obviously help in terms of disposition, in terms of assessing the risk of that patient, whether they are going to need inpatient services or outpatient resources are sufficient. And because of that, because of having a designated mental health team, it can help to reduce the length of ED stay and, of course, recidivism rates as well, which is of critical importance. So if you go to the next slide, we'll talk through some of the measures that were suggested. So as a global aim, our hope is that everyone who participates in this bundle will at minimum have some kind of written process to guide the care team and how to go about consulting a licensed counselor or mental health professional for pediatric patients with acute suicidality. So measure 1 is really just developing that written policy or process of how within your institution, within the resources that you have available, a care team would go about identifying a licensed mental health professional to evaluate your patient. The second measure is being able to develop a process that's accessible 24/7. In many cases, this is going to be via telemedicine. It can be in person, of course, but via telemedicine is certainly acceptable. But it's important that it's, again, with a licensed mental health professional for those patients who screen high risk for suicide. And then the last measure suggested in this bundle is having that clinical care process or guideline that requires all pediatric patients who screen high risk to receive a structured suicide assessment by a licensed mental health professional prior to discharge. So the first is, how do we do it? The second is making sure it's 24/7. And the third is requiring it as an everyday practice for every single patient who presents to the emergency department. So if you go to the next slide, what we're going to show next are some examples of some team-based models. These are highlighted in the Critical Crossroads Toolkit. And if you haven't had a chance to really dive into that resource, we very much encourage you to do so. It's on the EIC website. It's listed here as well. And there's just a tremendous amount of information, but we've tried to whittle it down a little bit here. So the mental health assessment, team-based models, the first one that's described is this child guidance model. This might work in a number of institutions where you have social workers readily available and present. And having a master's level social worker who's able to work in conjunction with a board certified psychiatrist can work collaboratively to make sure that every child is evaluated. And if the social worker provides that evaluation first, then they can escalate care as needed to a psychiatrist for those patients that may be a little bit more complex. The benefits of these is that, of course, it can reduce ED length of stay and ED costs, and being able to have that regular evaluation right there on the front lines in real time is ideal. Next slide, please. So a second model that's been proposed is the CARES model, or the Child and Adolescent Rapid Emergency Stabilization Model. And this is really an interdisciplinary care team, can be composed of social workers, counselors, psychiatrists, but also other disciplines. And it's really to help provide that ongoing psychiatric assessment and ongoing services. This particular care team would need ongoing training, and it would be best to consult with a licensed mental health professional in terms of making sure that this entire multidisciplinary team is working collaboratively to find the best disposition and plan for an individual patient. But this too can lead to significant decreases in length of stay for psychiatric patients that are seen in the emergency department. And Steve Rogers and others published on this. Next slide. So the Pediatric Emergency Department Psychiatric Team is another model. This may be a little bit more challenging unless you have higher level resources, but having a child psychiatrist working collaboratively with a mental health social worker. And in some follow-up studies, they were able to see that these patients indeed transition more appropriately to outpatient resources. It certainly decreased length of stay, and this is another model that could be adopted depending on the resources available to you at your institution. And then the last model, go to the next slide, is having really a dedicated mental health team. And the idea here is to have a mental health evaluator working along with a pediatric mental health specialist. And again, it's just that these types of team-based models who really are able to focus in on the needs of children in mental health crisis can really decrease length of stay, of course, but also improve satisfaction of the care team and providers, decrease bias in terms of ED interventions like physical restraints and the like, and also around other types of ED-based practices. So we really encourage you to think about that in your site and how you might pull together that kind of multidisciplinary mental health focused team. Next slide. So for those of you who really just don't have that kind of access available, you don't have social workers, you don't have access to licensed mental health counselors, then we have to begin thinking about other alternatives. And as was presented by Dr. Chip Schreiber in one of our prior sessions, you heard that as many as 66% of counties are designated mental health professional shortage areas. So we know how much of a strain this is for many parts of the country. So with respect to this work, as you heard from Jen Donathan, we have been beginning to partner with the HRSA grantees that are entitled Pediatric Mental Health Care Access programs. And these are programs that were really designed to help support primary care providers that have limited access to mental health services. And their goal was really to conduct training and help with coordination. They consult with those primary care providers to assist with assessment, to provide guidance and recommendations for treatment, and even help with referrals to specific outpatient resources. And the goal is really with the lens of health equity, especially for regions that are in more rural or remote areas or these health professional shortage areas. On the right-hand side, you can see a map of where all of the PMHCA grantees have been funded. Those, unfortunately, in gray do not yet have a PMHCA grantee or program. But even so, the lion's share of states do. And we've been working with 7 of these programs, and we'll highlight who those are in just a second, to begin looking at how they might expand their footprint to support services in the emergency department environment and provide consultation and recommendations. So if you go to the next slide, please. Here you'll see a graph of those PMHC programs that are excited to begin listening to, learning from all of you, and understanding how they might best begin to serve the emergency department setting. So those of you that are based in Washington, Oklahoma, Louisiana, Tennessee, Virginia, and Michigan, we're going to be so excited to introduce you to some of these PMHCA programs. Now, those of you who aren't in those states, there still may be opportunities to engage with PMHCA programs, and we'll be speaking more about that as we kind of move forward through this collaborative process. Next slide, please. Last, if you don't yet have a telepsych program or telehealth capabilities, there are a tremendous number of resources that have been developed. Also funded through the Health Resources and Services Administration is the National Consortium of Telehealth Resource Centers. They are regional resource centers. You can see the map on the right-hand side that describes kind of the regions that are being supported by a given telehealth resource center. And their goal is to educate people and organizations on how to implement these types of programs, how to provide ongoing education and training to healthcare teams and others who are beginning to develop these programs, and to troubleshoot and overcome some of the barriers that are associated with that. We encourage you to really look into these programs. If this is going to be your area of focus, mental health assessment, then this is a great way to begin looking at how you can expand or develop and establish an initial telehealth program. All right, next slide, please. So we're not going to map out every single change strategy for this bundle, but these are some examples. Again, why are we doing this? We're trying to ensure that we have a defined process for pediatric patients who screen high risk, defined process for them to receive a full suicide assessment by a licensed mental health professional prior to discharge. And the ways we might go about doing this is developing some communication strategies with our staff. We might begin to establish a telepsychiatry resource and thinking about the ways we might do that. You might think of ways you would educate staff on either a process for consulting licensed mental health professionals or educating them on telehealth services and how you can provide those more effectively or receive those more effectively, developing policies, and then other potential resources or knowledge reinforcement tools. So these are just examples to kind of get you thinking. And if you're planning on working on this bundle, just begin thinking about the ways that you might go about some of these change strategies. Next slide, please. So next week, we're so excited to welcome Dr. Vera Fuhr, who's going to be providing the fireside chat for this particular bundle. It'll be from 12 to 1 p.m. Central Time. She's amazing, and I really encourage those of you, especially who are working on this bundle, to attend. If unfortunately you're not able to, we will be recording it and posting that session and the slides onto our website. So be looking out for that. And again, don't forget to register. Every single session that we have, we are asking for individuals to register. That's not only so that we can track who's participating, but also make sure that we're prepared to answer questions as needed for these sessions. All right. Next slide, please. So we're going to take a stretch break and go to poll question number 3. If you could launch the poll, please. So when working with a team, tell us a little bit about what role do you like to play? And yes, your preferred role does not need to be your designated role, and nobody's counting. These are all confidential, so feel free to put whatever you prefer. The good news here is it's looking like we have a pretty even distribution of where people like to serve. And I love the devil's advocates because we always need those. Are we sure this is going to work? Do we really think we can accomplish this? Really asking questions to dive in, but every project needs a leader, a doer, organizers, and certainly supporters and observers. And hopefully the supporter role is really not just stepping back and doing nothing, but continuing to communicate with the larger care team about how important this work is and really garnering support from others. So thanks for sharing that. All right, so we are going to move on to the next slide, and we're going to jump into bundle number 3. So this is ED-based interventions. So we've gone through when a child presents the emergency department, the recommendation for universal screening and using a validated screening tool. The next step is making sure that all these patients separate from the screening get a full suicide assessment by a licensed mental health professional. And then while that is being prepared or planned, the next step is what kind of interventions are these children going to receive. So we do know, and as I'm sure many of you are quite aware, we see some significant disparities when it comes to not just pediatric emergency care, but certainly in the setting of mental and behavioral health. Black and Hispanic children are much more likely to have mental behavioral health conditions, less likely to be seen by mental and behavioral health specialists, and are less likely to receive prescriptions for psychotropic medications than white children. Black children are also more likely to experience physical and pharmacologic restraints compared to other races and ethnicities, and they're more likely to be referred to the emergency department by schools. Having a standardized clinical care pathway helps to reduce clinician bias, because then we have a standard order set or standard pathway that everybody is following based on objective findings from our assessment. Even though we're recommending a standardized clinical care pathway, we want to emphasize that we're not condoning universal screening for all of these patients. In fact, the PIM Choosing Wisely campaign has identified this as a critical area of interest or focus, is to reduce universal screening labs because they are in general both costly and unnecessary. And studies have shown that these screening labs can cost as much as about $1,200 per patient and may not result in any specific findings. So as Jen Hoffman described when she presented this fireside chat, she talked about the importance of screening only based on assessment findings that indicate the need for those. And then just finally, with respect to this bundle, the emphasis, of course, is on safety, but also really encourage you all to begin thinking about family-centered care. I'm sure you've seen some of the articles that have been posted in, New York Times and other media veins where they talked about, prolonged boarding. Many of you have obviously experienced this. But how are we really supporting families during this extremely challenging time? So if you are focused on ED-based interventions, this is a great specific area that you might choose within that is, how do we really think about supporting families? Some have even called for what would be like a patient's bill of rights or a family bill of rights to begin thinking about how we would support them. Next slide, please. So for this particular bundle, the global aim is to have established a clinical care pathway for children who screen high risk. There are 4 proposed measures within this bundle. The first is to just have a pathway, really kind of a process map or guideline that directs the care team of when should I do this type of testing, when should we implement de-escalation techniques versus restraint, how do we begin to support the families, and so on and so forth. For the more advanced sides, especially those that have support from IT, and that might be another group that you bring onto your local team, is maybe developing a standardized order set, especially one that's integrated into the EMR. And that can really help care teams in kind of not just implementing the care pathway, but ensuring that it gets to the patient. And then next slide, please. We have 2 more proposed potential measures, and these are more stretch goals because we're beginning to really look at patient level outcomes with respect to these measures. So measure 3 is the presence of a quality review process to begin looking at utilization of the order set. So you would be going back and pulling charts and saying, was the order set used? And then the measure 4 is really looking at complete compliance with that. So for many of you who work in emergency departments, you might have an order set, but some people might deselect certain components. Getting to the actual compliance with the full order set is really what Measure 4 is speaking to. So if you were to choose one of these last two measures within ED-based interventions, be thinking about your data sampling techniques. Am I going to use a systematic approach? Can we use IT to support us and pull all of our patients and get numbers and automate it? But these are the important things to really consider. All right, next slide, please. So within the ED-based interventions, this is our care path. So after the screening, then it's really the triage of these patients. And this is so important to make sure that we get that patient to a safe environment. Again, referring back to Dr. Jen Hoffman, when she presented this fireside chat, she spent a lot of time about how we ensure a safe ED environment for these children, and triage is a critical component of that. We talked about the screening, of course. Sometimes that's done in the triage area, sometimes it's done back in the rooms, but really thinking about not just suicide screening, but other areas of screening that you can see here, like drug and alcohol screening, exposure to violence, so that we can think about trauma-informed care and the like. And then lastly, the ongoing assessments that we would consider. So if you go to the next slide, please. As Dr. Jen Hoffman had cited in her fireside chat, we don't have really great triage tools that can be used specifically for mental health. And one that has been recommended is the Australian mental health triage tool, representing that here, of really thinking about how we might identify the appropriate triage level for these patients as being immediate threat, physically restrained or severe agitation, mild to moderate agitation, having anxiety or depression without suicidal ideation, and or those with chronic symptoms. Next slide, please. The care pathway, again, this is just an example of what a care path might look like. It's really just a decision support tool for the care team about what step do I take next, what should I include, when, where, and how, to be able to manage specific clinical presentations. And then on the right-hand side is really just an example of what placement of an order set might look like. So the EMR optimization, how you would include that. Some have even included EMR optimization as part of the screening, and that's a great mechanism to ensure its full integration. Next slide, please. So just a couple more steps. I'm going to turn it over to Dr. Mosadinejad in just a couple minutes to talk about intervention bundle 4. But when you're thinking about the ED-based interventions, these are some things you might want to make sure are included in your care pathway. So triage that we just talked about, ensuring a safe room, including removal of personal belongings, integration of a family bill of rights that includes, for example, how you communicate with families, how you educate the families on reducing agitation, what resources to find. Also thinking about what you do when those patients are boarding in terms of exercise, exposure to the outdoors, and food. One approach might be to also develop personalized care plans and distraction techniques that can be provided to every single family. This is not dissimilar to like an asthma education plan, right? This is a plan that you could give to the families to say, here's what you can do with your child should you be discharged. And then, of course, how you apply trauma-informed care approaches, and really beginning to build this up as you move through the process. Next slide, please, is just an example again of a key driver diagram. So if the goal for this bundle is to establish a clinical care pathway, then how are you going to go about doing that? And again, we have some example buckets of key drivers that you might be thinking about. And I'm sure now that you've seen these multiple times, many of you are already thinking about what kind of strategies you might use. And for those of you that are interested, we'd love for you to share some of those in the chat for teams that might be choosing to work on this bundle. So feel free to share ideas or thoughts about some potential intervention strategies or change strategies that you would use, or maybe that you have used in your emergency department. And then next slide, please. Last, again, these are just some resources that were shared a while back by Dr. Jen Hoffman again, some distraction tools, poppets and things of that nature, lights. Sometimes EDs have the ability to create rooms specifically for children that are on the autism spectrum to help reduce agitation. These can also be used for children that just have agitation without being on the autism spectrum. Certainly having a room safety checklist can really help staff to make sure that you ensure that appropriate ED environment. And this is one that was borrowed from the New England Regional Behavioral Health Toolkit, which is on the EIC website. And then lastly, as you begin to think about interventions, what do we do specifically for agitation, such a challenging presentation and a lot of variability in care. And there's a great toolkit that's available on the EIC website on that. And we encourage you to go look there. And with that, I am going to turn the mic over to Dr. Mo Sadenajad to take us through Bundle 4.
Thank you so much, Kate. Really appreciate it. Sorry again, I was a little late fighting the LA traffic trying to get here. But I'll be talking a little bit about Intervention Bundle 4. Essentially, what do you do after you have made a decision that the patient is now ready to go and going to be discharged from the ED, and we all know that that's not when things end. So discharge and safety planning is the gist of Bundle 4. So a couple of things just as a matter of background. It's important to know that people are more vulnerable immediately after the ED discharge because that is the time that a lot of studies are showing is a significant increase in the rate of suicide, which usually within the first week and then definitely up to the first 3 months, they're considered to be at higher risk. So just imagine that as a very high priority vulnerability area for a patient. So discharge planning is extremely important. Also, we all have an issue with the fact that the majority of children and adolescents who get scheduled a office visit with a mental health professional do not attend that first visit, and up to 3 out of 4 don't attend their first visit. So that's a big problem. And one of the other things that's very important in discharge planning is to consider giving good anticipatory guidance and education regarding those high-risk items such as firearms and open access to large quantities of medication. Next slide, please. So this is basically our quality measures. So the aim is for the participants of this bundle, we want everybody to have some sort of a process or written material that they can hand off to patients and their families upon discharge from the ED for those cohort of patients that were deemed to be sufficiently high risk. So on the screening and assessment, they were on a high-end risk, even though they don't meet qualifications for admission as an inpatient, they're still sufficiently high risk enough. So the first measure is just specifically a written process or a checklist that people can use in a high risk. So one is a checklist. Did you discuss lethal means restrictions, firearm safety, medication safety? Is the safety planning itself something that is clear, understandable, and you have a support structure to help you with it? Again, the next one is provision of resources that specifically goes to the family, and the follow-up appointment, as we mentioned, is important. Measure 2 is similar to measure 1, but it is mostly the resource packet, which includes this information being included in the discharge instructions, provision of outpatient resources, and maybe a list of psychiatrists in the area that you can go to, as well as specific, perhaps bulleted, kind of just-in-time safety planning items, again, as well as providing additional guidance on lethal means. Next. So measures 3 and 4, these are the stretch goals. Remember, for this, you want to think about a way to measure your data and do some analytics. Percentage of physicians and nurse staff who you have some sort of a training for, who complete a training on how to counsel families on lethal means restriction, and on how to provide an adequate discharge planning. And measure 4 is the on the family side, the recipient side, how many families, what percentage of families are reporting actually having received anything structured like that on, say, on lethal means restriction and safety planning at the time of discharge from the ED. Next slide. So this is basically an example of a checklist. So the quality measures can include the proportion of people who got a scheduled follow-up appointment. And ideally, you want to do this in the next few days because, as we mentioned, the first 7 days are really critical, and then up to 3 months even, it could be high risk. Including the primary care medical home is very, very important for the primary care physician to be in the loop, because a lot of times people come to the ED and their primary care doesn't even know this happened. So a checklist item including what you're going to give them about lethal means restriction and access to weapons. The discharge instructions shouldn't just be pre-printed papers that you say, here you go. Somebody should actually review them, make sure family understands. If, for example, somebody has limited English proficiency and it does not become apparent in the beginning, it's important to also have these in a different language and to be able to have that appropriate language interpreter to assure that they actually understand the content as well. Crisis cards, safety plan, and the rest of it, as you can see, these are all self-explanatory. So it's good to have these as a checklist. Next. So this is our key driver. So those of you who participate in this bundle, the goal is by November 30 to have a process or written materials for safely discharging pediatric patients who are at high risk. So we're not talking about everybody who comes in with a suicide complaint, but that's cohort of patients that are high risk, to have some format in place. Ideally, that written materials are integrated into the EHR so they can be printed straight out of the EHR, but at least have some kind of a written material that includes also availability of additional resources, training of the staff and personnel, ability to provide education at the right level for the right patient. So that's an important piece. And we talk about EMR optimization. I would say this one when possible, because I know some EMRs are kind of complicated with interfacing with new material, but that would be a good goal to have. And then resources to help reinforce that knowledge. It'd be nice to have a reminder system that sends an email 2 weeks later and says, just letting you know, these are the resources, and perhaps even track some linked resources and see who actually clicked on them. And if they haven't, some kind of a system that says, hey, please go and look. Next. So this is just, again, an example of how having something like use of telepsychiatry or crisis center is going to help. This is actually coming straight out of Critical Crossroads tool. The importance of linking to the primary care physician, linkage to community mental health, resources for family at home, so that all caregivers of that patient are not only have this discussed with in one way or another, but also have a mechanism to be able to see what action items they have to follow. And again, I cannot emphasize enough how important it is, the medical home involvement. That is a very, very important piece of ensuring safety after an ED visit. Next. And so this is, again, resources this is kind of redundant a little bit, but this is coming off of the QR code is here for that suicide proof report, safe storage of medication and firearms. Brochures, again, I would not just say English and Spanish, but be able, whatever your community has other than English, those resources should be made available. For example, for us in LA, Korean, Spanish, even Farsi are 3 of the languages that we aspire to have our contents developed in. And specific to where are some of the mental health resources near you, some safety tips about how to dispose medication, especially expired medication that still may be working, as well as firearm storage. Important thing also, how to speak to your child, be able to understand that some kids respond to a certain way of speaking better than other ways. Again, this has to be customized, has to be tailored, and very important to have a way to document this in the electronic health record that you've had these counseling sessions and these are the things that you've addressed. particularly, as I said, with language preference being one of the items. And the QR code here takes you to the document that actually is a source for this. Next. So this is an example of a safety plan sheet. You don't have to use this one. There are plenty of them out there, but Stanley Brown one is one that is commonly used. I have the QR code here that takes you to the source document. So if you want to use that, it's a very self-explanatory kind of safety plan that is going to be discussed with the patient and all of their caregivers. And hopefully a copy of it is sent to the primary care physician as well. Next. Again, as Dr. Remick mentioned earlier, we are seriously proud of all the work that we have put at EIIC in our pediatric education and advocacy kits. And we have a complete pediatric education and advocacy being PEAK. We have a PEAK toolkit for suicide. Please go there and take a look. We have the entire Critical Crossroads document, the 104-page PDF in there. And there's a lot of content that's developed off of that. We have podcasts, we have webinars, we have infographics, we have algorithms, not only suicide, we also have a peak agitation. So if you ever wanted to look at strategies to verbally de-escalate an agitated child, because we know that at least 80% or more of children who are agitated can be verbally de-escalated without any need to resort to medications or physical restraints. So this is very, very important. And the verbal de-escalation tool that we developed has been vetted by a group of subject matter experts from multidisciplinary partnerships. And these are the same group of people who most of them are sitting at the same table when the Critical Crossroads tool by HRSA was being developed. So I just want to point that out. And there is going to be a fireside chat for this bundle. It's going to be by our good friend, Dr. Neil Uspel from Seattle Children's, whose great expertise, especially is in lethal means restriction. So he's going to be doing that March 16th from 12 to 1 p.m. Again, just to clarify, this is Central Standard Time. So if you're a different time zone, it will be a different time. Next. So I just quickly put in a trivia question if we had time, but if you can just put in your answer in the chat. So which of the following is true about suicide? Suicide rates usually decline after a visit discharge from the hospital. Simply having access to gun doesn't increase risk of suicide. Safety planning is a private matter, should not be discussed with family. 3 out of 4 adolescents will miss the first follow-up psychiatry appointment after an ED visit. And last, urban children are more likely to have suicidal ideation than children in rural communities. If you can just do me a favor and just put in your answer letter. I don't know why it's seeing all A's. It should be A through E. I apologize for this. So just think of it. I'm sorry, this is kind of switched over, but it should be A, B, C, D, E. Awesome. Next slide. So again, but this happened, but the correct answer is D. Up to 70% of adolescents miss their first psychiatry appointment. And also, it's a myth to think that urban children are at high risk. As a matter of fact, rural communities not only have great risk, but they have lack of access to resources. So completed suicide and subsequent suicides after an initial flag is a much bigger problem in rural and critical access areas. So keep that in mind. Next. And just for those of you who are going to be working on these bundles, remember that you're going to get a welcome kit. There's going to be some kind of format of familiarizing you with how to do an environmental scan. You kind of need that to decide what your current state is. And then from there, you can decide on your needs assessment and a gap analysis. But the environmental scale is always the first step to figure out what your current deficiencies and current standard processes are. You also will have access to a QI implementation guide, as well as the intervention bundle guides. Next, there's going to be some additional centralized resources related to that. If you can put up to the next slide, please. Yeah, so we're going to help you, and you guys help each other, really honestly, with the shared best practices. Any kind of wins, any kind of success stories, please feel free to share that, because one of the great advantages of collaboratives is that people are working with each other and learning from one another. It's not a competitive environment. It's actually, you would have thought of something that others haven't. So this is important to share. We also will provide QI coaching. We'll help you with measurement and data support, and there's a plan to have office hours in July, August to support all of you guys as well. Next. And I think that's the poll question 4. If somebody wants to tell me when I can move to the next slide, because I don't see the poll.
You can go ahead, Mo.
Okay, so can I go to the next slide? Okay, I think this would be near the end of my slide. So just remember, environmental scan is extremely critical, because that basically goes to what is your resources, what is your workforce, what is the team structure like, what sort of technologies you have available, and what has been the traditional culture, especially when it comes to managing a child or adolescent who walks through the door with suicidality. A lot of times the problem is we don't really have a standard approach. Every person that comes in, we'll make him a level 2. We put him as much of a private room, as far away from others as we can, and we will basically try to find the quickest opportunity to get a mental health assessment. And if that's your current state, but your desired state is that you want to have at least the ability to screen everybody and see which of those who present are the ones at higher risk and need to be expedited, kind of similar to what Dr. Remick showed with that Canadian, and that's not the Canadian, the Australian, almost a triage tool. I really love that. I wish we could actually use that as a triage tool, because not every presentation requires a one-on-one and requires kind of urgency and evaluation. So that kind of comes out in your gap analysis when you kind of figure out who is the high risk patient that you need to approach. So that would be a good thing to have an environmental scan started for. Next. And I think this is my last slide, and I'm gonna, after this, pass it on to Jason, but bottom line that by December 2023, if you participate in any of these bundles, the goal is to have one item related to what we just talked about, the key drivers for the 4 different bundles, with the goal of improving care processes for children who present with suicidal ideation. And to the right here, you have basically our timeline. So we are now in the first segment of the February-March, where we are getting acquainted. We are working on our QI planning. Our group is helping you get you oriented with those fireside chats with experts, as well as those webinar sessions. And the goal is for you guys to start becoming comfortable with which of the bundles you want to participate in. And we know there's going to be variations in how quickly people are ready for one of the bundles, but that'll take us into April, and that's the rest of the schedule. With that, I'll pass it on to Jason to take us the rest of the way.
Thank you, Mo. So we're going to kind of jump ahead to April to the learning sessions that are beginning this upcoming month. The upcoming learning and future learning sessions will have small group sessions where several individual site teams, a QI coach, specific subject matter experts will get together. And during those meetings, materials will be able to be shared by each group through a brief slide presentation. Ideally, as Mo had mentioned, these small groups of teams should function kind of like a larger team, with individual site groups actively participating, sharing ideas, and providing encouragement to other teams in the group. We can go to the next slide. So these sessions can be a lot of fun. They're really a wonderful time to share your projects, to learn from each other's ideas, challenges, and successes, and also to celebrate those. As mentioned previously, they also give us a chance to support each other and give feedback and other suggestions about potential steps to help make our projects more successful. And as a bonus, These breakout groups are a wonderful opportunity for networking to develop connections that can help with this project and with other projects down the road. So these groups are kind of a big win all across the board. Next slide. As far as the team presentations go, each group will be sharing a brief 5-minute presentation during the breakout session. Each group should prepare slides to share that will streamline the content that is presented. This requires a little preparation, but does not need to be super complicated or time consuming. Again, this is a great place to share questions, concerns, or challenges that you may encounter and to seek input from others about potential solutions. And we will be sharing a slide template that can be used to help with putting these presentations together if needed. Next slide. For the upcoming breakout session, it will be beneficial to share information about your site and team so that we can all become familiar with each other and better understand and help each other. And to that end, maybe including a brief bio about team members would be great to share, including why you decided to participate in the collaborative. And if it's possible to throw pictures in, pictures are great. Everybody loves seeing smiling maskless faces, and it's always helpful to be able to put a face to names of people that you're working with. Next slide. Other pertinent things to include are these that are listed here: where you're located, what type of community you serve, urban, suburban, rural, what your hospital's like, how many children you care for every year, what kinds of pediatric services you provide, and do you have any pediatric trained staff, any staff that are specifically pediatric trained. And really, this is important to get to know each other again, because we all work at a unique place with its own sets of resources and constraints that really influences how we care for patients. So included in this presentation, you should also share your current pediatric mental health care clinical processes, including screening, assessment, interventions, and disposition. Who performs the steps? How do your resources affect how this gets done? Also, looking forward, it's beneficial to explain which areas of care your group wants to focus on going forward and why. And if there's any specific needs that your group has, it's also helpful to share. Another thing that you should share would be a draft SMART aim. And we've already talked a lot about SMART aims being specific, measurable, achievable, relevant, and time-bound. But you should share your team's SMART aim and what changes you plan on making and the next planned steps for your team going forward. And again, remember that all of this doesn't have to be perfect on day one. As we get together and discuss our projects, teams will be able to refine and adjust strategies as appropriate. And next, we're going to turn the time back over to Laura just to take it home.
Thank you, Jason, and thank you to all of the speakers. I appreciate all of you staying on to the end with us here, so please get ready for the poll, which will be the evaluation in just a short second. Information related to MOC Part 4 credits is here on the screen and will be in the slide presentation that will be posted online as well. Next. Here is the information for nursing contact hours. You can use the QR code right now and go directly to the place where you request your credit hours. And Robin has her name here in the slide in case anybody has questions or comments. Next. And the social workers and the other professionals that we mentioned in the chat can get to their link to their own survey and follow up through that link right there. Lastly, I just wanted to thank everybody who's filled out a participant demographic form. We still have a few of you whom we would like you to complete the form. Thank you so much. Most of you have finished the environmental scan, which is a very important planning tool to help guide your future work. If you haven't done it and you need help, just let us know. We'd be happy. And then we will let you know when the bundles and other resources are ready and are posted online via email. And I will send you some other additional updates and details that we might have missed along the way too. And then one last thing, if you'd like to name your team as we form these breakout groups, that is perfectly appropriate. So I'll send information out to you as to how you can do that and how you can officially declare and file information on the bundle topic that you're choosing and some details about your QI project. Please complete the evaluation poll, which we hope will show up on your screen shortly.
So Laura, for some reason it's not launching for mine. Can one of the other co-hosts see if they can launch that poll?
It looks like it's launching and I don't have any responses there yet.
It just takes a few minutes for people to type in names and stuff. Thank you all for completing the poll. We really appreciate hearing your thoughts so we can make improvements to these sessions moving forward. Thank you guys so much for your time today, and we are beyond thrilled to work with you all over these next 9 months.
Yeah, and I just want just to reemphasize what Laura said, it would be really cool if you guys can think of a cool name for your team that makes you kind of unique and we can market your name. That'd be awesome. Instead of just calling it team number X or Y.
Thank you so much. Have a nice day.